Every 66 seconds, someone in America is told they have dementia. Most of them have been waiting for that appointment for months. They've been watching themselves forget names, repeat sentences, lose a word mid-thought. They've been scared, and the people who love them have been scared. So they sit in that office and they hear dementia, and they leave believing they have entered a decline that cannot be stopped and cannot be reversed. But here is what nobody tells them to check first. For a meaningful portion of people who receive that diagnosis, particularly people over 60 who are on multiple daily medications, the cognitive decline that brought them to that appointment is not, or not entirely, what it appears to be. It is not necessarily Alzheimer's. It is not necessarily irreversible. It is, at least in some cases, a side effect, a documented, researched, consistently underreported side effect of medications that millions of seniors take every single day. Some of those medications are prescriptions from a specialist. Some are prescriptions from a primary care doctor who has been refilling them for 10 years without a conversation about what they do to an aging brain. And some, this is the part that stops most people cold, some are over the counter. Things you pick up at the pharmacy without anyone asking your age or reviewing your medical history. 9 of those medications are what this video is about. Quick note before we start. This channel is for general education, not medical advice. I am not your doctor. Nothing in this video is a diagnosis or a prescription, and please never stop or change any medication on your own based on what you hear here. Always talk with your doctor or pharmacist first. That conversation is the whole point of what we're building toward today. What this channel does is explain the why, not just the what, not just here's a list, but here's the mechanism. Here's what's actually happening inside your brain when these medications are on board. And more importantly, here's the question you can bring to your doctor that could change the picture. Today, 9 medications that research has linked to cognitive decline, memory loss, confusion, and, in some cases, symptoms serious enough to be mistaken for early dementia. 9 medications that are in common use. 9 medications that almost nobody explains to seniors when the prescription is written. Watch for number 1 on this list, because number 1 is not actually a single medication. It is something that can happen when you are already taking 2 or 3 of the medications on this list at the same time, and your doctor, looking at each prescription in isolation, may have no way of knowing it's happening. It is the thing behind the thing, and it is almost certainly the single most important piece of information on this entire list for anyone over 60 on more than 2 daily medications. We'll get there, but only if you stay through number 2. Here's what almost no one explains when any of these 9 medications gets prescribed. Most of the drugs on this list, not all but most, belong to a category called anticholinergic. It's a long word, so let's break it down into something you'll actually remember. Your brain communicates with itself through chemical messengers. These are not signals in a vague, metaphorical sense. They are actual molecules produced by specific cells that carry specific instructions from one part of your neural network to another. One of the most important of these messengers, especially for memory, learning, focus, and clarity of thought, is a molecule called acetylcholine. Acetylcholine is the messenger your brain uses when you try to recall a name, when you learn something new, when you hold a thought in your working memory long enough to complete a sentence, when you navigate a familiar route without losing your place. It is one of the primary chemical signals of conscious, deliberate cognition, and its activity in the brain tends to decline naturally with age, which is part of why memory and processing speed slow somewhat in our 60s, 70s, and beyond. Now think of your brain as a communication network, a set of lines and channels through which these messenger signals travel. Acetylcholine is the signal. The cells that respond to acetylcholine are the receivers on the other end of those lines. Anticholinergic drugs work by blocking those receivers, not erasing the signal, blocking the receiver. The message is sent, acetylcholine is released, but the cell on the other end has been given something that clogs its receptor so the message never gets through. The line goes quiet, not permanently in a single dose. When the drug clears your system, the receptors open back up. But with consistent daily use over weeks and months and years, that repeated quieting of the acetylcholine signal starts to look less like a temporary interruption and more like a chronic communication failure. And in a brain that already has less acetylcholine activity than it did at 40 or 50, because that's what aging does to every brain, adding a drug that further suppresses what's left is not a small thing. It is adding silence to a system that is already quieter than it used to be. This is the mechanism behind most of the medications on today's list. Some are strong anticholinergics. They block the signal powerfully. Some are moderate, and some work through different mechanisms entirely. But all 9 have documented researched associations with cognitive symptoms in older adults, including symptoms serious enough to be mistaken for the early stages of Alzheimer's disease. That distinction, mistaken for Alzheimer's, is the most important phrase in this entire video, because Alzheimer's is not reversible, but drug-induced cognitive decline, in many cases, is. That is what makes this conversation worth having. Number 9, and we're starting here because this is the one most people never see coming. The most commonly used sleep aid in America is not a prescription. It is available in every pharmacy, every grocery store, every gas station. You can buy it without a prescription, without anyone checking your age, without anyone reviewing your other medications. It goes by many brand names: Zazquil, Unisom sleep tabs, the PM version of Tylenol, Advil PM, and most generic nighttime or PM pain relievers. The active ingredient that makes all of them work as a sleep aid is a single molecule, diphenhydramine. Most people know diphenhydramine as the active ingredient in Benadryl, the allergy medication, and it works as a sleep aid for a simple reason. It is a powerful anticholinergic. It makes you drowsy by doing the same thing we just described in the primer. It quiets the acetylcholine signal throughout your nervous system, which slows your brain's activity and makes you fall asleep. The everyday image. If acetylcholine is the signal keeping the lights on in your brain's communication network, diphenhydramine is like dimming those lights until you fall asleep. For a young person, the lights come back up fully when the drug clears their system in a few hours. For someone over 60, the dimmer switch doesn't always return to the same position. There is a reason the American Geriatric Society's Beers criteria, a widely respected list of medications that are potentially inappropriate for older adults, lists diphenhydramine with a specific warning about cognitive impairment. Research has consistently found that older adults who use diphenhydramine regularly show measurably worse performance on memory and processing tests compared to non-users, and those deficits can persist well beyond the acute sedating effect of the drug. Let me stop here for just a moment. Even when we talk about blood sugar, kidneys, sleep, or everyday senior health habits, one thing is always connected: the heart. That's why the team at Senior Insight Press created Heart Safe After 60, a simple guide to help seniors spot the warning signs before it's too late. It's a complete 55-page guide that covers every cardiac warning sign, the 10-minute emergency protocol, the overnight protection system, and a 90-day heart protection plan you can start implementing today. Most importantly, it includes the full list of cardiac tests your doctor may never have ordered for you, including the lipoprotein A measurement and the coronary artery calcium score that can predict a cardiac event with remarkable precision. The link is in the description. It's from Senior Insight Press, published specifically for adults over 60 who refuse to leave their heart health to chance. Now, let's get back to our topic. The safe action. Check every sleep aid, PM pain reliever, or nighttime cold and allergy product in your medicine cabinet for diphenhydramine or diphenhydramine HCl on the active ingredients label. For occasional use, alternatives like melatonin at low doses, 1 to 3 milligrams, or doxylamine, which is also sedating but has a somewhat different side effect profile, may be options to discuss with your doctor. Consistent difficulty sleeping deserves a conversation with your doctor, not a nightly OTC anticholinergic. And number 8 is something most people grab for completely different reasons and never think of as a brain medication at all. Number 8 is a category that lives in medicine cabinets across the country under the label of allergy medication or cold medicine. First-generation antihistamines, the ones that came before the modern non-drowsy formulas, include chlorpheniramine, brompheniramine, and diphenhydramine in its allergy application. These are found in countless combination cold medications, in many generic allergy tablets, and in some medications marketed for hives or itching. They are significantly older drug formulations, and they are significantly more problematic for the aging brain than the newer generation they largely replaced. The mechanism is the same one from the primer. These drugs cross the blood-brain barrier, meaning they don't just work on the histamine receptors in your nose and sinuses, they also reach the brain itself, where they block acetylcholine receptors alongside the histamine receptors they're targeting. This dual blocking action is why they make you drowsy. And in older adults, that same dual action is why they raise concern. Think of it like this. A first-generation antihistamine is like taking a sledgehammer to a thumbtack. It does the job of reducing histamine, the allergy symptom driver, but it takes out a section of your brain's communication infrastructure at the same time. The second-generation antihistamines, loratadine, sold as Claritin, cetirizine, sold as Zyrtec, fexofenadine, sold as Allegra, were specifically designed not to cross the blood-brain barrier in significant amounts. They handle the histamine in your nose without reaching the acetylcholine receptors in your brain. They are the recommended alternative for older adults on every major geriatric medication guidance list. The safe action. Check your allergy and cold medications for chlorpheniramine, brompheniramine, or diphenhydramine in the active ingredients. Ask your doctor or pharmacist about switching to a second-generation antihistamine for ongoing allergy management. The newer options are equally available over the counter, generally at similar cost, and they are not on any list of medications associated with cognitive decline. Number 7 is one that surprises people because it's often prescribed specifically to help seniors maintain their independence, and its cognitive trade-off is almost never mentioned in that context. Number 7 is a category that is prescribed to millions of seniors for one of the most common and quality of life affecting conditions in older adults: overactive bladder and urinary incontinence. The medications in this category include oxybutynin, sold as Ditropan, and tolterodine, sold as Detrol, along with sulfenacin, darafenacin, and several other related drugs. They are effective at what they're designed to do. They relax the bladder muscle and reduce the frequency of urgency and involuntary leakage, which is a very real problem that significantly affects independence, sleep, and daily life for a large number of people over 60. But here's what is almost never explained when these medications are prescribed. These drugs are among the most potent anticholinergics in common medical use. Particularly oxybutynin, in its older immediate-release form, has one of the highest measured scores on what researchers call the Anticholinergic Cognitive Burden Scale, a standardized rating of how strongly a drug disrupts acetylcholine function in the brain. The reason is pharmaceutical design. Bladder control requires acetylcholine signaling in the bladder's smooth muscle. That's how the bladder knows to hold versus release. Blocking that signal reduces urgency, but the drug doesn't stay in the bladder. It travels through the bloodstream, crosses into the brain, and blocks the same type of receptors there, the receptors your brain uses for memory, learning, and attention. The everyday image, using a high-strength anticholinergic bladder medication, is like turning down the volume on the entire radio, not just on one channel. The channel you wanted to quiet, bladder urgency, gets quieter. But so does everything else the signal was carrying. Research on oxybutynin in older adults has found cognitive performance deficits, particularly in verbal memory and processing speed, that are measurable within weeks of starting the medication, and in some studies, persistent in ways that do not fully reverse when the drug is stopped, especially after long-term use. The American Geriatric Society Beers criteria explicitly lists oxybutynin and several of its relatives as medications to avoid in older adults precisely because of this profile. The safe action: if you or someone you care about has been prescribed a bladder medication, this is a conversation worth having specifically with the prescribing doctor. There is a newer class of bladder medication, beta-3 adrenergic agonists, specifically mirabegron, sold as Mirbatrix, that works through a completely different mechanism, does not have the anticholinergic profile, and is considered a safer option for older adults. The trade-off on effectiveness and side effects is different, and the decision is individual. But the question, is there an alternative to this medication that doesn't carry an anticholinergic burden, is the right question to ask. And number 6 is a medication that most people associate with a pulled muscle or a bad back, not with their brain. Number 6 is one of the most commonly prescribed medications for an experience nearly everyone has had: back pain, neck pain, muscle spasm after an injury or a strain. The drugs in this category, cyclobenzaprine, sold as Flexeril, carisoprodol, sold as Soma, methocarbamol, or phenadrine, are prescribed because they work for acute pain. They relax muscle tension, they break the spasm cycle, and for a short-term acute injury in a young or middle-aged person, they may be entirely appropriate. In a person over 60, they are a different calculation entirely. Cyclobenzaprine, the most widely prescribed muscle relaxant in the United States, is structurally related to the tricyclic antidepressants, a drug class we'll come back to at number 5. That structural relationship matters because it shares some of their pharmacological properties, including meaningful anticholinergic activity. It also crosses the blood-brain barrier, which is why it causes sedation. And in older adults, that sedation comes with cognitive effects that extend well beyond the feeling of drowsiness. The mechanism, cyclobenzaprine, quiets the acetylcholine signal alongside the muscle tension signals it's targeting. The brain and the muscle are not separate territories. The same chemical messengers are at work in both. Block them in the peripheral nervous system to relax a muscle, and you're also blocking them centrally in the brain. Think of it like trying to turn down the volume on one speaker in a connected sound system. The knob that controls that speaker also lowers the volume in the adjacent room. Research on muscle relaxants in older adults has consistently found elevated rates of confusion, memory impairment, falls, and what clinicians call delirium, an acute, sometimes severe disruption of cognitive function that can look very much like sudden onset dementia. The Beers criteria lists all muscle relaxants as potentially inappropriate for older adults, primarily because of this cognitive and fall risk profile. The safe action: muscle relaxants are often prescribed for short-term use, days, not months, and the concern is greatest when they are extended beyond that window or prescribed repeatedly for chronic pain. If you are taking a muscle relaxant on an ongoing basis for a chronic condition, that is a conversation worth having specifically about whether it remains the right option or whether physical therapy, anti-inflammatory strategies, or other approaches might provide relief with less cognitive trade-off. Number 5 is one that shocks people. Because it's not a painkiller or a sleep aid, it's an antidepressant. Number 5 requires a careful distinction up front, because antidepressants is a broad category, and most antidepressants in common use today do not carry significant anticholinergic burden. The ones we're talking about are specific. The first group, tricyclic antidepressants. These are older antidepressants developed in the 1950s and 60s that include amitriptyline, sold as Elavil, nortriptyline, imipramine, doxepin at higher doses. In the 1980s and early 1990s, these were first-line treatments for depression. Today, they are less commonly prescribed as antidepressants precisely because newer, safer options exist. but they have not disappeared from prescribing. They are still used for nerve pain, for migraines, for insomnia, and in some older patients for depression when other options have been tried. Amitriptyline has one of the highest anticholinergic burden scores of any commonly prescribed medication. Period. It is more potently anticholinergic than most of the bladder medications, most of the sleep aids, and most of the antihistamines. It was designed in an era when the cognitive trade-offs in older adults were not well studied, and a significant number of people over 60 are on it today, sometimes without any reevaluation of whether it remains the right choice for their current situation. The second drug in this category worth naming specifically, paroxetine, sold as Paxil. Paroxetine is an SSRI, a modern antidepressant, and SSR is as a class are generally considered much safer than tricyclics for older adults. But paroxetine is the exception within that class. It has a meaningfully higher anticholinergic burden than other SSR is like sertraline, escitalopram, or fluoxetine, and in older adults, that difference can be clinically significant. The mechanism for both is the same as the primer, anticholinergic activity that crosses into the brain and quiets the acetylcholine messenger system, compounding the natural age-related decline in acetylcholine that every person over 60 is already experiencing. Think of it this way. If the aging brain already has fewer functioning communication lines than it did at 35, a high-burden anticholinergic antidepressant is like taking offline some of the lines that were still working. Research on tricyclic antidepressants in older adults has shown associations with measurable cognitive decline, including in domains specifically associated with early Alzheimer's presentations, episodic memory, verbal fluency, processing speed. These are the same domains that would show up on a screening cognitive assessment. It is not difficult to see how a patient experiencing tricyclic-induced cognitive decline could, in a brief appointment, receive a dementia workup rather than a medication review. The safe action: if you are taking amitriptyline, nortriptyline, imipramine, or paroxetine for any purpose, not just depression, bring it to your prescriber's attention and ask specifically, is there an alternative to this medication with a lower anticholinergic burden that would serve the same purpose? For nerve pain, there are gabapentin alternatives, SNRIs, and topical options. For sleep, there are non-anticholinergic options. For depression, there are multiple SSRIs with far cleaner cognitive profiles. The question is whether the switch is appropriate for your individual situation. Number 4 works through a completely different mechanism, not anticholinergic at all, and its connection to cognitive decline is the one most likely to be contested or explained away. Don't let that happen before you hear the full picture. Number 4 is a category that is prescribed for anxiety, for sleep, for muscle spasm, for seizures, and after certain procedures. Benzodiazepines, alprazolam, Xanax, lorazepam, Ativan, diazepam, Valium, clonazepam, Klonopin, are among the most prescribed medications in the United States, and they are disproportionately prescribed to older adults. The mechanism here is different from everything else on this list. Benzodiazepines are not anticholinergic. They work on a different system entirely, the GABA system, which is the brain's primary inhibitory network. GABA is a neurotransmitter that slows neural activity. It's the brain's natural calming signal. Benzodiazepines amplify GABA's effect, which is why they reduce anxiety, induce sleep, relax muscle tension, and stop seizures. But amplifying the brain's inhibitory signal has a cost, and in older adults that cost is significantly higher than in younger people. Here's the everyday image. If your brain's activity is a city with traffic flowing through it, GABA is the traffic control system. It manages the flow, prevents gridlock, keeps things calm. Benzodiazepines are like switching all the traffic lights to slow mode at the same time. The gridlock resolves, but traffic is including essential traffic, cognitive traffic, the information flow you depend on for memory and clear thinking, slows down everywhere, not just in the anxious or overactive areas. In a 30-year-old brain, that slowdown is temporary and relatively well tolerated. In a 65-year-old brain that is already running slightly slower than it used to, the slowdown may cross a threshold that is visible and significant. Memory encoding, the process of converting short-term experience into retrievable long-term memory, is particularly vulnerable to this kind of GABA enhancement. The research on benzodiazepines and cognitive impairment in older adults is extensive. A significant body of observational research has found associations between long-term benzodiazepine use and cognitive decline, including dementia diagnoses. A 2014 study published in the BMJ involving over 2,000 people found that benzodiazepine use was associated with an approximately 50% increased odds of an Alzheimer's disease diagnosis in those who had used these medications for more than 6 months. One important nuance the framework requires us to state honestly. Observational studies like this carry a significant methodological challenge called reverse causation. It is possible that some of the people in these studies were already showing early signs of dementia, particularly anxiety and sleep disruption, which are common early symptoms, and that is why they were prescribed benzodiazepines, not the other way around. The relationship between the drug and the diagnosis may, in some cases, be reversed from what it appears. But long-term benzodiazepine use is also associated with measurable acute cognitive effects, memory impairment, confusion, slowed reaction time, and a significantly elevated fall risk that are not disputed and that are present during the period of use regardless of what happens over decades. For these reasons, the Beers criteria explicitly lists long-acting benzodiazepines, diazepam, clonazepam, flurazepam, as medications to avoid in older adults, and recommends caution even with short-acting forms like lorazepam and alprazolam. The safe action. If you take a benzodiazepine regularly, not just occasionally for a specific situation but daily or near daily, this is a high-priority conversation with your doctor. The research is sufficiently consistent to make it worth asking, are there alternatives for what I'm taking this for, anxiety, sleep, that don't carry this profile in older adults? Tapering off benzodiazepines when appropriate is a process that must be done gradually and under medical supervision. Never stop abruptly. The withdrawal effects can be serious, but the conversation about whether long-term use remains appropriate is one worth having. Number 3. I told you at the beginning to watch for this one. It starts with a G, and if you've been prescribed it in the last 3 years for pain, for nerve symptoms, for sleep, or for anxiety, this is the one you need to hear. Number 3 is the one that doesn't show up on most lists like this, and that is exactly the problem. Gabapentin, sold as Neurontin, and pregabalin, sold as Lyrica, are not in the same class as the other medications we've covered. They were originally developed as anticonvulsants, medications for seizure disorders, but over the past 15 to 20 years, they have become two of the most widely prescribed drugs in the United States for off-label uses: nerve pain, neuropathy, sciatica, fibromyalgia, post-surgical pain, sleep, anxiety, and restless leg syndrome. Prescriptions for gabapentin in older adults have increased dramatically, by some estimates more than tripling over the past 2 decades. It is now one of the most commonly prescribed medications in the 60 and older population, and a large proportion of those prescriptions are for conditions that do not have strong evidence supporting gabapentin's effectiveness, but that do have very real evidence supporting its cognitive side effects. Here's the mechanism. Gabapentin and pregabalin work by binding to a specific subunit of calcium channels in the nervous system, channels involved in the release of several neurotransmitters, including glutamate, the brain's primary excitatory messenger. By reducing calcium channel activity, they dampen neural excitability, which reduces nerve pain signals, reduces seizure activity, and promotes sedation. The everyday image. If the brain's neural activity is an amplifier turned up too high, which is what happens in nerve pain and seizures, Gabapentin is like turning the gain down. In the right context, that's the right intervention. But in an older brain, turning the gain down doesn't just quiet the pain signal, it quiets the whole amplifier. Memory consolidation, attention, processing speed, word finding, these all require active, energetic neural signaling. Dampen the whole system, and those functions suffer. The cognitive side effects of gabapentin in older adults are well documented in clinical trials, not theoretical, not just observational associations, but reported adverse effects in the studies that got the drug approved: dizziness, sedation, difficulty with concentration and memory, and confusion. These effects are more pronounced in older adults who metabolize the drug more slowly and whose neural baseline is already more sensitive to any additional dampening. Research on long-term gabapentin use in older adults has raised additional concerns about persistent cognitive effects. Studies have found associations between extended gabapentin use and measures of cognitive impairment in older populations. What is less clearly established is whether this relationship is driven by the drug's direct effect on the brain, by the conditions it's treating, or by some combination. The science is evolving and is not as settled as the anticholinergic evidence. But here's what is settled. The Beers criteria added gabapentin and pregabalin to its list of medications requiring caution in older adults, specifically because of fall risk and cognitive adverse effects, and the pattern of broad, often undifferentiated prescribing of gabapentin for conditions where its effectiveness is limited, sleep, general anxiety, non-neuropathic pain, creates a situation where older adults are absorbing a drug with real cognitive trade-offs for benefits that may not be delivering what was promised. The safe action: if you are on gabapentin or pregabalin, the first question is what it was prescribed for and whether it's working for that purpose. If you started it for nerve pain or seizures and it is clearly helping, that is a different risk-benefit calculation than if you're on it for sleep or general pain with unclear results. Ask your doctor specifically, is there evidence this medication is working for what I'm taking it for? And given my age, are there alternatives with a lower cognitive side effect profile? This is a conversation about reevaluating a prescription that may have been written in a different context than where you are now.